I'll be discussing the topic in 5 headings: anatomy, epidemiology, pathophysiology, presentation and diagnosis, and the management. So briefly coming into the anatomy, the function of the foot and ankle is basically to maintain stability of the limb, to ensure adequate mobility, and to protect the underlying bony structures from erosion due to the constant pressure and impact of walking. So it is briefly divided into 26 bones, and of which of importance to us are the forefoot, which includes the metatarsals and the phalanges, the midfoot, that is the cuboid, cuneiform and navicular bone, and the hindfoot, which is the thallus and calcaneum. And it has a total of 25 joints, of which the calcaneal and talonavicular and calcaneo-cuboid joints are very important in case of eversion and other joints. And it has multiple ligaments, with the three major facial ligaments being the extensor, flexor, and the peroneal retinacular. It has 5 major facial components. These components need to be opened, especially when there's a contiguous spread of infection, because of which it is very important surgically when in case we're dealing with a diabetic foot infection. So there are multiple fasciotomy and approaches to these compartments, and plantar, which has 4, and dorsal, which has 2 compartments. And muscles of the foot are mainly divided into the 4 layers. Their important role is to not only ensure there's an adequate stability, but also help in the movement of the toes and fingers. Mainly they are the flexor compartment. So the 4 layers are as follows, and the dorsal musculature of the extensor compartment is present. So a brief account of the normal gait biomechanics. So the walking cycle of any human is divided into the stance phase when the foot is on the ground, and and it is the swing phase when the foot is off the ground. So the stance phase is about 60% of the gait cycle, and it's initiated by the heel strike, and this is the transfer of the body load to the foot, which is absorbed, and this characterizes the heel strike portion, which is the initial part. As the foot progresses, the body mass continues to move forward over the fixed foot, and it initiates toe off in the second portion of the stance phase. In this, it is important to make out that the foot is a lever which acts as a support for the load which is generated, and this is all extended across the metatarsals and the joint along with the tips. So this is the normal windlass effect which is seen in case of joint. And the various phases of the heel cycle, which is important here, basically in case of the subtalar joint, which is inversion and eversion, and during the maintenance and cycle phase. So coming into going through this brief account, let us come to the epidemiology of a diabetic foot. So it has an annual mortality rate of a diabetic foot ulcer is 10% per year, and about 20% per year it is associated with amputation. So, and even in those patients which undergo an amputation on one side, it has been shown that 40% undergo amputation on the contralateral limb after 3 years. The cost of treatment for a diabetic foot ulcer is extremely high, and it ranges from $8,000 to $17,000, which is a significant occurrence. It is a very disheartening fact to know that up to every 20 seconds, a patient undergoes amputation for a diabetic foot ulcer. The burden of the disease is going to increase as we have more greater number of cases of diabetic foot diabetes being diagnosed in the person, and the late diagnosis and neuropathy are the most common cause for a diabetic foot ulcer. So let us go into the pathophysiology. There are 5 main principal pathophysiologies as to the contributing to the diabetic foot ulcers. That is the diabetic neuropathy, which is the most important, the coexistence of peripheral arterial disease, which is predominantly below the knee disease or the infrapopliteal disease, the presence of soft tissue infections, and the muscle and bone abnormalities, which includes the presence of altered joint biomechanics and callosities and erosions, and other comorbidities, which is commonly seen in these patients with diabetic. So each one of them we can discuss separately. So the diabetic neuropathy, it is both a sensory and an autonomic neuropathy. So this, because of the sensory neuropathy, there's an absence of sensation of the foot, which causes them to inability to sense when there is pain. There is a loss of temperature sensation which is present. So there is a heat and cold perception is lost. And the autonomic neuropathy, which causes reduction in the amount of sweating, and also the AV shunting is an important risk factor for the development of a diabetic foot ulcer. The peripheral arterial disease is a second important contributor, with about 50% of the diabetic foot ulcers are a direct contribution from the existing peripheral arterial disease. It is attributable to about 70% of the mortality in these patients. Higher risk of digital artery and the smaller vessel disease, and the infrapopliteal occlusive disease with heavy calcification is the classic. So multiple studies as to the extent of this peripheral arterial disease has been done. So it was found by Gilzini and all that they found in angiographic pattern, they found that 36% of the patients had multiple occlusions and stenosis in the tibial, peroneal, and femoropopliteal segment. And all 3 vessels were occluded in 27% of the patients. So this is the more predominant pattern we see in a diabetic foot ulcer, which is a below the knee disease. So this is the representation which is commonly seen. And it is also noticed that long segment occlusions in these lesions are very common in these patients. Then the presence of soft tissue infections. The diabetic foot ulcer may not present with infections. So the important thing to note that most of these ulcers are colonized. So in the absence of clinical suspicion, that is the presence of erythema greater than 2 centimeters or frank pus discharge or fever, which is rarely present in up to 50%, wound swabs are unnecessary and they have no prognostic role. The other methods of wound culture are more important. So based on that, we have multiple severity systems. One of the most commonly done is our Wi-Fi classification, which includes the presence of infection. And commonly in the presence of systemic infection, it is considered as a high grade of infection. Next, based on the outcome, this is a PDIS classification, which we are commonly seen. We see that our patients with presence of severe infection have a much lower rate of wound healing and a higher rates of amputation, which is grade 3 and grade 4 infections. So muscle and bone abnormalities. So the most important etiological risk factor for the development of the ulcer is high plantar pressure which is present. So it was found that any plantar pressure greater than 6 kg per centimeter square is a very specific risk factor for the development of the diabetic foot ulcer. So this high plantar pressure can be due to the loss of sensation, coexistent neuropathy, and loss of contractures. Contractures such as the hematodeformity or arthropathy are specific risk factors as to why ulcerations develop commonly in the first metatarsal region. The changes in biomechanics commonly seen is both an increase in the mean and the peak plantar pressure, which is mentioned. There is clawing of the toes and hallux valgus deformity is present, which is the toe getting deviated laterally, and high and flat foot arches, which increase the plantar pressure and also alter the gait biomechanics, resulting in increased risk of ulcerations. So there is also a loss of causing a loss of the protection of fat pad due to the thinning, due to the altered foot biomechanics. This results in the development of risk factors for the ulceration. Other comorbidities are very common in these patients. It was shown by those patients with diabetic foot ulcers compared to diabetes alone had a statistically significant risk of the presence of higher incidence of hypertension, hypercholesterolemia, CAD, and CVA in these patients. And it was more commonly seen in men, as it is the most common incidence in our case. How do these patients present? So in any patient with a diabetic foot ulcer, so patient history, which includes the history of how many years of diabetes, the medications for diabetes, other history, and presence of any symptoms of significant diabetic neuropathy like paresthesias or acute pain sensations, and the number of admissions is important, and history of previous ulcerations or amputations done for these patients. The examination includes a general physical examination, a vascular examination, where it is important to note the peripheral pulses, capillary refill in the feet and toes. Neurological examination, it is done either include both the vibration sensation and the fine touch, which is done with a Simmons-Weinstein test, which is a 10-gram monofilament sensory event. And the vibration is done with a 128 Hz tuning fork, wherein which we keep it over the bony prominences, and about 20 seconds as the normal perception time for this vibration. Anything less than that, we can consider that it is a suspicion of a neuropathy. Ulcer depth and the ulcer characteristics need to be informed, and an important test is a probe to bone test, which has a high sensitivity for the diagnosis of an osteomyelitis patient. And musculoskeletal, it is always important to look for their gait, and and if possible in a standing position to look for any deformities like flat foot or changes in the arches. So diabetic ulcer, how do you evaluate these patients? Infection. An infection is suspicion when there is erythema or there's a redness more than 2 centimeters from the normal ulcer, or there's a soft tissue edema. Probe to bone test, which is a suspicion of osteomyelitis, has a high sensitivity and specificity, and systemic signs, although rare, are an important factor and are highly specific for the presence of a diabetic foot ulceration. So there are multiple classification systems which are commonly used. We use the University of Texas system, the Meggitt-Wagner system, and the IDSA system. Commonly used is the which is familiar to most of us is Meggitt-Wagner, and the IDSA system which is present. So based on the IDSA system, it is more where severe is when there is systemic factors or signs of SIRS, and 3 is usually when there is a cellulitis which is extending greater than 2 centimeters, or lymphangiectasia, or a localized cellulitis with gangrene. One is when usually considered mild infection, where there is wound is lacking. So we're taking this into a nutshell. The commonly used classification for these ulcers is the Wi-Fi classification, which is done for even for the critical limb ischemia patients. So they are divided into wound, ischemia, foot, and total score is done. So any ischemia is critical limb ischemia is those in which there is a risk of greater loss. So based on this ischemic classification, grade 3 ischemia is those critical limb ischemia where there is an ankle systolic pressure of less than 50 and a toe pressure of less than 30. Infection is again divided based on the IDSA PDIS classification. So when to manage infection first and when to manage when to think of revascularization. Any neuroischemic foot with tissue loss of grade 2 and grade 3 with a high, it is better to manage the ischemic foot. An acute ischemic foot, if severe infection, concomitant infection is present, always remember the dictum is to manage infection first. Any infection grade 3 SIRS features, better to manage the infection first. So the risk stratification is present in all these patients who present to us. So there's an ADA classification which is present. So any patient with a very high risk, like loss of protective sensation, these patients need to be appropriately screened and referred for diabetic foot ulcerations. Now, next is the component of imaging. X-ray of the foot is a very important investigation, and this should always be done weight bearing to assess for the deformity. A sensitivity of 22 to 75%, which is a wide range for osteomyelitis. The most common X-ray finding being soft tissue increase as in the soft tissue edema, which can be seen. MRI with contrast has a very high sensitivity and specificity for osteomyelitis, and newer like WBC scan, the perfusion assessment are done. So in treatment, we often come to this question as to how to treat these patients, admission versus outpatient. Sir, is it visible, sir?
Yes, go on.
So in the treatment, so we often have this dictum admission, how to treat these patients. So the general principle of management of these patients is whether they require inpatient admission or can be managed on OP basis. Management of blood sugars is extremely important in these patients. Offloading, which is to ensure that there is an equal distribution and reduction in the plantar pressure. The management of the wound and adequate patient and patient bystander education is a cornerstone for this management. So how do you manage the wound? Wound debridement. Wound debridement is also known as the wound bed preparation, is an important aspect in the management of a diabetic foot. So it is to alter the environment of the wound to promote healing by remodeling of the abnormal tissues. So basically it is to ensure that high levels of matrix metalloproteases like MMP9 and other substances like necrotic tissue which is present, which is commonly attributed to a chronic inflammatory stage in these wounds, is altered to ensure better healing of the wound. So the goal of any debridement is to have a well-perfused wound bed with quantitative cultures with less than 10 to the power of 5 colony-forming units in tissue before adequate closure. There are multiple modalities, but commonly used is sharp debridement. There are other modalities like hydrojet, Versajet, which are commonly used for debridement. Next is offloading. The principle of offloading is to minimize the pressure on the wound and to help in heal ulcers. So meta-analysis shows that a total contact casting shows greater efficacy. So what is total contact casting? It is a semi-rigid boot. The mechanism is the plantar pressure is evenly distributed throughout the sole of the foot, and it is also transferred to the lower leg. So it was initially used in the management of leprosy patients, but it has found a greater role in the management of a diabetic foot ulcer patients. The patient education, it is very often important that these patients suddenly undergo deterioration and infection, and the family needs to be educated regarding the warning signs for these patients who have subsequently require admission. It is also important that these patients, especially with those wearing total contact casting, to maximize the compliance with therapy, so adequate patient in and it is important to explain to both the patient and the bystanders the adequate warning signs to ensure the early presentation to the hospital. So what are the soft tissue surgeries which can be done for the patient with diabetic foot? So you have diabetic foot ulcer, you have a healthy wound bed. So what are the options for the coverage? So you have local tissue flaps and free tissue flaps, each which have contraindications for both. The contraindications for a local tissue flap are gross contamination, extensive disease, and a peripheral arterial occlusive disease. Commonly mentioned that any ABI less than 0.5, it's a relative contraindication for a local flap. Free tissue transfer like free flaps, their absolute contraindication is a poor surgical risk patient, below the knee disease, and a psychiatric disorders and a non-functional limb. Relative contraindication include those patients with ESRD, with end-stage renal disease. Amputation. When to it is not a failure of a treatment. Aim is to get the patient back to productivity. Revision amputation or amputation is quite common in these patients, and it is very often seen that amputation is both a curative treatment in case of extensive infection, or sometimes in those frail patients, it is found that return to functional activity is greater after an amputation than repeated debridement and prolonged care. So it should not be considered a failure of treatment, but an option, be it a last option in their treatment management. They have a higher risk of amputation in these patients because 20% can still undergo the contralateral limb amputation because of the bilateral nature of the disease. So how do you manage the PAD? So it is very important that it is lower extremity involvement, characteristic involved tibials, and may spare the pedal vessels or the toe vessels and called sparing microvascular. So the indications for revascularization are similar to non-diabetic patients, which include critical limb lesions or those present with acute limb. So any patient with non-palpable pedal pulses or tissue loss or non-healing ulcers need to be evaluated in the vascular lab. Commonly used methods are the ankle brachial index, which is less reliable in a diabetic patient because of the extensive calcification of the tibial vessels, and ABI may commonly be non-compressible. So in these patients, a toe brachial index or a pulse wave waveform or a TCPO2, which is the tissue concentration of oxygen and skin perfusion pressure, are commonly used in these patients. So what are the predictors of wound healing in a patient with PAD? So a toe brachial index greater than 0.6 is predictive of a tissue healing, which means an adequate supply, or a TCPO2 of greater than 40 mm of Hg. A TCPO2 greater than this one 0.6 is predictive of wound healing, but it is also in the presence of absence of disorder. So what do you intervene? So the main method of revascularizing these patients is by endovascular intervention. So the planning for any extra endovascular, this one is to delineate the anatomy, classify the extent of the disease, and appropriate classifications have been done called the glass classification, and use the appropriate hardware or the intervention, or if required, the surgical modality in those specific group of patients based on the criteria. So based on that, you can use either an open versus an endovascular based on the patient characteristics. So this I've taken from one of the articles. So in this, it says that after CTA is not usually recommended because of the poor infraparietal visualization. So either it can, certain patients can go directly for a diagnostic catheter angiography or MR angiography, depending on the availability in the lesion. So define the target arterial pathway is an important characteristic. So normally the glass classification and the grading has been done. So in these patients, this grading gives to extent, based on this grading, you have the extent of the complexity. So a high complexity disease means an expected greater failure rate of more than 20%, and which also correlates with limb-based patency and rates of limb loss in these patients. So what is the problem with the endovascular management? These patients are predominantly BTK disease, which have a poor 1-year patency in the tune of 30 to 40%. Now, whether to use of drug-coated balloons, there is a trial called Debate BTK trial. So the role of drug-coated balloons has shown better patency, but whether or not it should be used is still a matter of question. Stent, it is used predominantly as a bailout option. It is not used as a routine management of BTK disease. When do you do bypass? Some studies show better healing with bypass. The problem in the diabetic foot patients is these patients have a pedal sparing, but they have a tibial disease more commonly involved. So they require long lengths of bypass graft liquid. And many of these patients have a very poor conduit because they have had coexistent cardiovascular disease. So a CABG is very common. So an inadequate vein conduit. This inadequate vein conduit and the occasional presence of end-stage renal disease means that the presence of the desert foot configuration is quite common in these patients. What is the best option? Best CLI trial results are awaited. So the take-home message for the patient with a diabetic foot ulcer is always multimodality approach. Patient education is crucial to the compliance, especially with regard to the identification of the warning sign, early presentation, and for compliance of treatment. Preventing of a recurrent ulcer by meticulous follow-up and adequate examination, which is yearly. Good glycemic control. And for any patient with PVD requiring revascularization, based on the patient, it is prudent to choose the appropriate modality. Managing infection and importantly, offloading measures. Thank you.